So in my talk this evening, I will tell you a bit about my background and how I came to be a statistician. And then I will introduce my discipline and give you an example of misleading research and why this matters to patients. And finally, I'll give you a small sample of the varied epidemiological and clinical trials research I've been involved in over the past 3 decades. So I was born and raised in a small port town on the Isle of Skye in the Scottish Highlands. And here I am on the left as a baby with my sister Linda, who unfortunately could not be here this evening. And on the lower right-hand side there is the only high school on the island, which I attended with Graham, who's in the audience here this evening. Welcome. And this campus has long since been replaced with a modern campus. Now, there's a proverb that says that it takes a village to raise a child, and I think that was definitely true of our upbringing in our small community. I always had a keen interest in science, as is evidenced in this photo in the middle here. And I soon got my first computer, which I was very excited about, a Welsh-built Dragon 32. Which occupied me on countless rainy days, especially waiting for programs to load from the cassette tapes. So that just dates it a little bit. And I was very keen on maths at school, so I was fortunate to have, Graham and I were fortunate to have teachers Brian and Heather Forehand, and they inspired me to study the subject further. So for those of you that haven't been, I really recommend a trip to Skye to enjoy its dramatic landscapes. So in our penultimate year in school, we filled a minibus and we set off from Portree, which is the blue arrow here, and we toured the university towns of Scotland, which was a lot of fun. So we did that for a week so that we could work out where we wanted to go and study. And bear in mind that all of these university towns were at least 200 miles away from home. And so leaving the Highlands for higher education was an inevitability. So I opted to study mathematical sciences at the University of Strathclyde in Glasgow. And on the right-hand side, you can see rather splendid Art Deco buildings. This was the very noisy Baird Hall residence. And that's where I lived for my first year. In the middle, you can see buildings, less attractive buildings, where we had our lectures and seminars, and fellow Strathclyders in the audience will recognise those buildings. And on the left-hand side here is the magnificent Kelvingrove Art Gallery and Museum, where I spent quite a lot of my free time, and still do when I visit Glasgow today. In my final year on my course, I worked part-time at the Health Board's Department of Public Health and Medicine, and also did my dissertation project there as well, which was in asthma research. And so that inspired me with, alongside my course, where I was getting really a lot more interested in statistics. So that in combination with my work experience attracted me to apply for a master's in medical statistics. So I was fortunate to win a studentship, and I went to study at the London School of Hygiene and Tropical Medicine, which you can see there on the left. And I lived in these rather handsome halls of residence here at Marble Arch, which is a great spot to get to know London. And this is a picture of our course group here with some of our tutors, and what a wonderful year it was. So what is statistics? So one definition says that it's the study of populations, variation, and methods for the reduction of data. Now that sounds really quite dry, doesn't it? So effectively, statistics is not just a toolbox of methods. It gives us ways of reasoning in a world full of uncertainty, variation, and chance. Now in this painting here we see Florence Nightingale, and we already heard about Florence earlier from Richard. So what some of you may not know is that Florence is, she was well known as a statistician as well, and during the Crimean War, she meticulously collated data on soldier mortality, and she presented this in innovative ways which influenced hospital and sanitary policy at the time. Now, the statistics developed rapidly as a discipline in the first half of the 20th century, and we can see from the establishment of the first statistical departments through to publication of one of the first textbooks by Woods and Russell on medical statistics, down to two landmark studies, one a randomised controlled trial of streptomycin for tuberculosis, which is what we think of as a modern trial. It's really the first sort of modern trial which we recognise today. And then there was Dolan Hill's landmark paper on the link between smoking and lung cancer as well. So we can really get a flavour of why statistics is very useful. But at a basic level, we can take data from a sample of people here, for example, and we could use simple descriptive statistics to say something about that group of people, so the average and spread of information about them. But we can also infer something about that population from the sample, and that is where statistical inference comes in, and that's why it's so important in health research. So for those of you in the room unversed in statistics, this is just a brief introduction to one of the basic inferential frameworks in statistics called hypothesis testing. And we start, say for example, imagine we have a group of patients with heart failure, and we want to see whether a new treatment is better than an existing one for measuring, for improving their quality of life over a 12-week period. So the study goes something like this. So we start with consenting the patients, so we recruit them into our study and measure their quality of life at baseline. Then we randomise them to one of the two treatments. So what does that mean? So basically that leaves their allocation down to chance, and what that achieves is that the groups are very similar at the outset. So then they have their treatments, hopefully they will take the treatments, and then at the end of the study, at 12 weeks, we again measure their quality of life in their follow-up appointments, and then we work out the average change in quality of life in the two groups and compare these. So the question that we ask is, are these averages more different from each other than we'd expect by chance variation alone? So the strength of evidence against a null hypothesis is given by what we call the p-value, and the smaller that number, the stronger the evidence we have that there's a treatment difference. So this table here just gives a very brief introduction to the basic framework of hypothesis testing. So we have here at the top, we've got our trial sample, so we observe our result in our trial sample that we've just conducted the trial in these heart failure patients, and we either find a statistically significant difference in their quality of life between the two treatments, or we don't. But down the side is the unknown truth whether this treatment works or not in the whole population. And so there either is a true difference in quality of life between these treatments, or there isn't. So that gives us four possibilities. Four possible conclusions. So we've got two that are correct, potentially. So we can either find a true negative result or a true positive result, shown in green font. Or we can find a false negative result or a false positive result, shown in red font. And sorry, I appreciate red and green, perhaps not the best colour combination. Anyway, and also we have our statistical power, so that's the probability or chance of finding a positive result if there is one. And on the other flip side, we've got the significance level, which is the probability of finding a false positive result. And we try to maximize our statistical power, and so we've got the best chance of finding a treatment difference if there is one, and then we try to minimize the chance of a false positive finding. So we quite often set power to about 80% at least, and our significance level of 5% or lower. So what's this got to do with data fishing? So data fishing is carrying out unplanned statistical tests to try and find something interesting. And many unwitting researchers keen to get their research published can end up doing this. But the problem with this is that the risk of false positive findings increases. And it's quite easy to show that for every 20 independent hypothesis tests that we conduct at the conventional 5% significance level, assuming all of the null hypotheses are true, then we have a probability of at least 64% that we'll get at least one positive result. And that's quite a high probability, really. So if we know in advance that we're going to be conducting lots of tests, we can do a correction for multiple testing so that we set a stronger threshold for significance. So why does this matter in practice? Well, the reason is because trial results can influence health policy and the sorts of treatments that patients are offered. And one well-known example to illustrate the problem is paroxetine for adolescent depression, which is known as Study 329. So this was reported as safe and effective in a paper in 2001. But it was found that the original paper had used selective reporting and post-hoc outcome analyses. So that's effectively looking at the data and conducting further analyses based on what you've observed in your results. So a reanalysis by Lenuri and colleagues later found no evidence of efficacy, and they also found that harms had been underplayed in the original study. So harms particularly increased risk of suicidality. So this really underlines the importance of pre-specifying analyses in a statistical analysis plan, correcting for multiple testing where appropriate, and reporting results transparently. So as an applied statistician, in contrast to many academics who would tend to focus careers often on very specific topics, applied methodologists like myself often work across a very broad range of areas, as we can see up here. And over the past 30 years, I've worked in all of these areas, some more than others, using a great diversity of different study designs as well. So back to my timeline. So after completing my master's, I went to St. George's down in Tooting to work with Ross Anderson and colleagues on air pollution epidemiology. And so epidemiology is a discipline concerned with the distribution and determinants of health and disease in populations. So on the right-hand side here, you can see rather hazy Nelson's column in Trafalgar Square. And this was taken during the Great Smog of London in 1952. And at that time, daily deaths were increasing rapidly and peaked at 543 deaths on the 10th of December. And this led to, a few years later, the Clean Air Act coming into law. In the middle here, you see me in one of the windowless offices I occupied at St. George's, and this is where I sat and meticulously analysed daily counts of hospital admissions and mortality in relation to antecedent measurements of air pollution from monitors across London. And these analyses, this work used quite sophisticated, what we call time series models, and they were, so these involve conducting hundreds of pre-planned tests, and it's worth to look at patterns of association, but it's worth mentioning at this point that in epidemiology, corrections for multiple testing are not routinely applied except in, for example, genome-wide association studies. So these are some of my early papers from this work, including my debut paper at the top here, which I was very pleased to get published in Occupational Environmental Medicine. So some of this work went on to influence UK air quality strategy, and we also conducted panel studies where we measured lung function repeatedly in individuals and related those to air pollution measurements over time. So I won't go into the details of any of the results of these studies because there was a lot of work in this area that I was involved in. But in the year 2000, I went to sunny Brazil, and I spent that year there. And this is one of my most highly cited papers, which I worked on with colleagues at the University of São Paulo, which looked at the association between air pollution and birth weight. Now, we found an inverse relationship between carbon monoxide concentrations in the first trimester of pregnancy and subsequent birth weight. Then I returned to St. George's the following year, and I was a research assistant, and I also embarked on a part-time PhD as well with Derek Cook, so using two large English general practice databases, I retrospectively followed up patient records from birth and examined exposure to antibacterials, immunizations, and infections. So look at the hygiene hypothesis. Now, the hygiene hypothesis proposes that reduced exposures to infections in early life may be associated with increased risk of allergy. Conducting hundreds of pre-planned statistical tests, I didn't find any evidence of association there. So the raw data sets for these studies ran to millions of records, and we could take a day or two to process on the mainframe computer. So more often I would leave a job running on Friday evening and then return Monday morning, only to find I'd left a semicolon off my syntax. And so, of course, I had to start running all over again. So that was quite tedious. Just before submitting my thesis, I moved to the Healthcare Commission in London to work on NHS patient surveys and staff surveys, before returning to academia a year later. So I moved to Queen Mary in East London and to the Centre for Health Sciences to work with Sandra Eldridge and colleagues in the room this evening. And I hadn't worked on trials before, so there was a lot to learn. In trials, in contrast to the epidemiological studies that I mentioned earlier, often in trials, we're looking at one primary hypothesis that we want to test on the primary outcome. So one of the most complex and challenging projects I worked on was OPERA. So OPERA was a pragmatic trial of a physiotherapist-led exercise intervention for depression in elderly care home residents. And this was a cluster randomised trial where homes rather than individuals are randomised, and homes deliver the intervention or continue as usual. Now, the outcome of the trial was that we didn't find any benefit of the intervention, and so it couldn't be recommended in practice. But nevertheless, even though it was a negative trial, it was scientifically very robust. And it was a very large trial as well. There was over 1,000 participants in the trial. And so we were very pleased to get it published in the Lancet. But for me, this study was something of a baptism of fire, hence my choice of image here on the right-hand side. And I really did feel the heat when I was doing the analysis. But on the flip side, our trials office was filled with raucous humour. And you can ask me for more details over drinks later. So in 2015, I'd seen this job advert which looked like this is written for me, and it was at Brighton Sussex Medical School, and it was to be my first permanent post. and it was looking for experience in epidemiology and in clinical trials, so big data and trials. So I thought, okay, this is for me. I applied and fortunate to get a post, so I went and moved down to Brighton and Sussex Medical School on the edge of Brighton. Now, BSMS had not had a statistician in place really since it opened in 2003. So I quickly found myself deluged with requests for advice and input onto grant applications. So I set up a statistics clinic, and with my colleague Chris Jones, we provided ad hoc advice to hundreds of researchers over the years to try and meet some of that demand. I was also closely involved with the development of the Brighton and Sussex Clinical Trials Unit. So that's one of a network of over 50 such units around the UK. And trials units design, run, manage, and analyse high-quality trials to national and international standards. So the unit achieved full accreditation with the UK Clinical Research Collaboration in 2023, which was very satisfying. And during my time at BSMS, I grew my statistics team from just myself to 4 of us, and it's great to see so many trials unit colleagues here this evening. Soon after joining BSMS, I started to work on the REDUCE feasibility trial. So REDUCE, so this was led by Brighton hepatologist Smita Verma. So REDUCE asked the question, could we run a definitive trial of long-term abdominal drains for patients with advanced liver disease? So patients with advanced liver disease get ascites, so lots of fluid gathering in the abdomen, it's extremely painful, and it has to be drained at regular intervals. So the point of this trial was really to look at whether it would be possible to run a big trial which would help patients spend more time at home towards the end of their life than having to return repeatedly to hospital. So it's one of the many feasibility studies that I've worked on over the years. And these studies are not designed to test hypotheses, unlike the other studies I mentioned earlier, but rather to resolve uncertainties about whether a trial can be done, how it should be done, and whether it should be done at all. And that matters because poorly designed research at scale is unethical, it wastes money, and the time and energy of patients, clinicians, and researchers as well. So fortunately, REDUCE demonstrated feasibility, and this helped us secure major funding for the definitive trial, which is ongoing currently and due to report results next year. And it's gratifying to see our study used as a shining example of a decentralised trial in the NIHR's latest Good Clinical Practice training. And you'll hear more about trials research from my colleague Monica in her lecture up just a bit later. So what's the future of pilot and feasibility studies? In the UK, years people are living in good health are declining. And at the same time, the population is aging. And this is putting even greater pressure on already stretched healthcare services. So meeting the challenge to resolve this requires continuous innovation, and whether through digital health technologies, artificial intelligence, or smarter ways of delivering care, and this must be underpinned by more efficient research, including greater use of routine healthcare data in trials and innovative trial designs. But every novel approach brings fresh uncertainties, and this is exactly where pilot and feasibility studies sit. They help us identify those uncertainties and resolve them so that our research has the best chance of succeeding. So perhaps that emphasis on uncertainty reflects my own career. As you may have gathered, I've never had a focused career plan. What I've tended to do is seize opportunities and take the odd risk, and I think that's served me quite well. And I'd strongly encourage anybody considering pursuing a career in statistics to do so. And In the age of big data and artificial intelligence, these skills are more sought after than ever. So in this brief lecture, I hope I've shown you that applied statistics and epidemiology are not just a collection of methods. They're also about asking better questions, avoiding being misled, and producing evidence that genuinely improves patient lives through prevention, treatment, and healthcare delivery. So the examples I've shown from epidemiology and clinical trials may seem quite disparate, but they're united by a common purpose, and that's ensuring that research evidence serves society well. And before handing back to my colleague Glenn, I return to the idea that it takes a village to raise a child. It also takes an academic community to raise a researcher. And these are just some of the people from school teachers all the way to present-day colleagues who've supported, nurtured, supervised, mentored, and inspired me. Most of all, I thank my parents, both of whom died from chronic lung disease. My mother didn't receive meaningful palliative care, but my father did. Today would actually have been his birthday. So my sister especially, and I were privileged to care for him at home towards the end of his life, well, at the end of his life. And that experience is part of what really begins, working closely with our faculty, Cicely Saunders Institute of Palliative Care, Policy and Rehabilitation. So I can't name everyone who's made it possible for me to be stood here this evening, but I'm grateful to all the colleagues, collaborators, friends and family who've supported me with such generosity. Thank you.